There's some recent evidence to show that the LVEP seems to be all over the place. I don't know if that's a reflection of LV stiffness, because a lot of these, chronic renal disease patients have hypertension and have LVH, and as a result, their lusitropy and EDPDRs are such steep curves that a cup of fluid is enough to put them pre or post, pulmonary edema. So, is there a role for active PA pressure monitoring, right heart cath monitoring in these patients to shoot for a hemodynamic quote pneumonia, so the right pressure between 5 and 8? And if that's what you choose to do, what percentage of patients are you actually doing post-PCI physiology, assuming that they're euvolemic, so you're not really perturbed results based on hemodynamics, to judge whether or not you actually achieve what you're trying to achieve, especially now what we're seeing for defined GPS and the role for post-PCI physiology.
Yeah, so there's no data to suggest that you need to monitor with a PA catheter for just the immediate setting. So you're continuing fluids for 4 hours post-procedure. And I get that these patients can be tenuous, but that's why you're sort of scaling it according to the LVEP that they're at. They're based, at least what they randomized 400 patients in the Poseidon trial, and since then I've been doing this quite frequently. For those 4 hours, we're not really seeing, unless they have concomitant severe valvular disease, in which case I scale back the fluids, or extremely low EF, so an ejection fraction less than 20%, again, I'll scale back the fluids. But otherwise, just based on kidney disease alone, we haven't really seen that clinically in terms of the 4 hours based on the LVEP guidance. Now if their LVEP is up or even in the middle to begin with, then already you're scaling down the fluids. And if you look at the bottle of Snapple, that's 250 cc's. So it's really not that much.
Yeah, so we've analyzed our data over the last few years. So there's about 350 zero contrast or ultra low contrast in this group. And what we're learning is, number one, residual renal function, so residual urine output. We know our data is actually one of the most potent predictors of long-term outcome. And so the reason I asked about the analysis, the question around dialysis in these patients who are dialysis dependent already, does that mean you have sort of free rein to do whatever you want? And the answer is no. And so dialysis post-procedure is a very reasonable thing to do, but the key is not to recommend UF. And the best guidance for that is actually the post-PCI wedge pressure. Maintaining the wedge pressure around 14 or so in the majority of these patients, assuming no MR, seems to be the sweet spot based on these preliminary, not yet peer-reviewed data. And the other important point to make around the LVEP spread, this is data from St. Francis data, is that the LVEP spread is very wide. And the presumption is that maybe because the LVEP is a gross measure of intracardiac pressure and is functionally dependent on how thick the wall is, right? And that's variable, which is why there's now this question of maybe a more sensitive indicator is the use of right heart cath early on. There's a meta-analysis that I just reviewed that looks at the utility of right heart cath to direct shock management. And comparing that to LVEP measures seems to suggest that right heart cath has got more data, but again, that's a shock population. So who knows? The diastolic function is abnormal, systolic function is abnormal.
No, so first let me talk about the dialysis patients, you're 100% spot on. In fact, it's not just making urine or not. So obviously you don't want to go from making urine to anuric, which is why we say even though the patient's on dialysis, like you said, that doesn't mean you can give 1,000 cc's of contrast. You still want to be judicious. But there's also some data to suggest that with continued insult to the injury with the contrast or with the higher doses of contrast, you decrease their time to needing a transplant.
Absolutely.
So they end up needing a transplant sooner than you would think. I think with the right heart cath, we can hardly get people to image arteries when, I think you'd be hard pressed to apply a right heart cath for 4 hours post-procedure. And yes, there are going to be some extreme cases where you want to know the whole.
I'm thinking my brain post.
We don't have evidence for that yet, right?
Yeah.
It's a very good discussion. we are half an hour behind. I just to ask one question so we can move on. But right heart cath, if somebody wants to do a clinical trial comparing right heart cath versus the EDT guided CIN, in addition to post-acid trial, if you can do that trial.
Well, just to say, you can also look at your stroke volume index on echo, and that can give you some guidance as well.
Aisha.
I just want to ask you to address the issue of access in NSAID and also the guide cat size. Presumably, there is some data to show that using a small French guide reduces downstream CIN, and also you want to preserve the radio for a potential fistula. If you could address those two issues.
Yeah, so there's some nice data actually from our group that looked at the radial arteries that were harvested for bypass, and they looked at the pathological specimens. So when they harvested the radial arteries from the site where the catheterization took place, all of the changes happened within within 5 to 10 millimeters of the actual access site, but not proximally. And it's the proximal second that's used for bypass. So this whole idea that you can't go radial because you want to save the radial artery for a bypass graft, that's not true. And in fact, the surgeons are happy to still use that bypass. In terms of the fistula approach, we'll tell you that most of the fistulas will fail on the venous side, not on the arterial side. And our nephrologists insist that we continue to use radial, even if there's a future plan for a fistula on that side, because it decreases the bleeding risk and they haven't had any issues with their fistula placement. So we still use radial. In fact, I would argue that CKD patients are at highest risk for bleeding complications and vascular complications, and so you really should push the envelope for radial there. In terms of French catheter size, the smaller the better. There's a reason why we have a lot of AKI after TAVRs. Those are huge sheets and huge devices that are going through. In fact, my aortic stenosis patients, the few rare patients that are left that require a VAV, if they have renal insufficiency, I'll actually go bi-radial for the VAV to bypass the renal arteries. Because if I go femorally, I have to use this 11 French system, and I'm going through the descending aorta with a lot of plaque. So that's true, but when I'm going radially, honestly, I stay with the 6 French to be able to maneuver around as much as possible.
Thank you. Vinita, we are running short of time. Excellent presentation and discussion, Dr. Vinita. Thank you. Now I request Professor Fazilatunisa Malik, renowned cardiologist, not in Bangladesh, but worldwide, and she will present application late main PCI and his discussion. I request Professor Fazilatunisa Malik.
Friends and colleagues, it's indeed a great honor and privilege for me to be here today. And it's not Uwe. Should notice it's stuck there. Sorry about that. So, friends and colleagues, fingers crossed. So today I'll be talking about trifurcation left main PCI. Now, when do we have a trifurcation? It seems it's pretty common. 12 to 15% of all the cases we have a trifurcation, and we call it a significant trifurcation when the ramus intermedius is above the size of 2.25. And actually, if you look at the literature, there's not much in the literature about how to tackle a left-wing trifurcation. However, in most cases, we advocate CABG. There have been some small studies about trifurcation, and the usual consensus is that we should try to keep the procedure as simple as possible. And that's what we did for this case. This was a left-main trifurcation. The LAD was a C2, and after opening up the LAD, what we did is we did pre-dilatation. We did a single step from the left main to the LAD, deployed a stent, did proximal optimization, and to treat a bifurcation stent, you really do need proximal optimization. The final result was spot on, and 3 years down the road, the result was great. So keeping it simple really usually works in the vast majority of cases. But what if the trifurcation is really complex and you've got a huge blood burden? What do you do then? And what if the modified Medina classification is 1, 1, 1, 1, and your ramus is a large size vessel? I'd like to share a case with you which I just had. So this is a 57-year-old gentleman who presented to us with non-ST segment elevation myocardial infarction. He had multiple risk factors for coronary artery disease, and his entrance in our hospital was somewhat dramatic because after he came to our hospital in the emergency, he developed VT, a cardiac arrest. The doctors then immediately gave DC shock, CPR. He came back, and once he stabilized, he was brought to the cath lab. His ejection fraction was 40%. So in the cath lab, we found that he was quite stable, and we did his angiogram. The right coronary artery was quite all right. However, it was giving collaterals to the left side. And in the left side, we found that there was a short left main with an 80 to 90% stenosis involving the trifurcation. The LCs had a 95% stenosis, ramus a 99% stenosis, and the LAD was totally occluded from its origin. So what should we do? We first attempted to wire the LAD. And why did we do a PCI? But at that point of time, it was not possible for us to arrange a CABG immediately. And so we decided and opted for a PCI. Pictures have gone. I'm sorry if Minhas would come and rescue. The pictures can't be seen there. So what we did is we decided that we would have to do a PCI. We knew that doing a PCI would not be easy because doing a PCI would not be easy because the anatomy was the pictures sort of just back. So doing a PCI would not be easy, but however, we knew that at that time to safeguard our patients, we would have to do a PCI, and that's what we did. And we were very careful of how to do the procedure. So what we did is, the pictures aren't there, so I'm sorry I don't make any sense of it. So first of all, we opened up the LAD. After opening up the LAD, we did pre-dilatation of the ramus by opening up the ramus. Now the crux of the matter was the LCX, and in the LCX, this was going to be tough because the LCX was a heavily angulated vessel, and it had a 99% stenosis in its origin. But the LCX was a large size vessel, and we knew that we could not afford to use that. So what we did is we took another guide catheter through the radial loop with the intent to treat the LCX. Once we took our catheter through the radial loop, we gently disengaged the catheter, the previous one from the femoral loop, and we positioned our guide catheter from the radial loop we then, with gentle maneuver, pushed the wire into the rammers. We put back the wire from the rammers, which we had previously placed through the femoral root, and this we gently maneuvered into the LCS. So, as I said, the femoral catheter is slightly disengaged, radial lead catheter is engaged, and we wired the rammers. And the rammers wire was pulled back and it was placed in the LCS. So now we were in business, we had managed to wire all 3 vessels, and then we proceeded to do pre-dilatation of the LCS.